Okay, I have 11 o'clock, so I think we're going to go ahead and get started. Good morning, everyone, and thank you for joining our webinar today titled Summer Burn Injuries, Initial Patient Care Considerations for Pre-Hospital and Hospital Providers. My name is Judy Plasek, and I currently serve as the Burn Specialty Team Lead for the Region 7 Disaster Health Response Ecosystem Grant. This webinar objectives for the webinar are to identify burn injuries that are commonly seen with summer activities, discuss emergency care priorities for a patient with burn injuries, and list the American Burn Association referral criteria for burn injuries that should be referred to a burn center. This webinar is accredited for 1 hour of continuing education credit and will be available at the conclusion of the webinar. Today's speaker will not be discussing any off-label uses of products. And our disclosures, our speaker and members of the planning committee do not have any disclosures except for Dr. Lawler, whose disclosures are listed here on the slide. If you have any questions or comments, please use the Q&A function on your screen, as we will be monitoring the Q&A box throughout the presentation and should have time at the end of the presentation to go through them. And after this presentation, you may access your CME certificate by signing into the unmc.edu/CCE site, or by following the prompts to create an account and use the activity code 54046 to receive your credit for today's webinar. So it is my pleasure to introduce our speaker for today's webinar, Dr. David Voigt. Dr. Voigt has been a burn and trauma surgeon for many years at St. Elizabeth's Regional Burn and Wound Center in Lincoln, Nebraska. His current professional and academic appointments include Director of Burn Research. He is Co-Medical Director of the Burn and Wound Center and was recently Chief of Staff at CHI St. Elizabeth's. Dr. Voigt is also a Clinical Assistant Professor of Surgery at Creighton University and UNMC here in Omaha, and serves as a member of the Nebraska State Trauma Advisory Board. He has authored over 60 burn publications and is involved in burn disaster preparedness efforts across the state. Dr. Voigt, welcome. We look forward to your presentation, and I will turn it over to you.
Thank you. Thanks to everybody who's in attendance. It's always a pleasure to share with you what we do here at our Regional Burn Center. So today we're going to talk a little bit about some burns that are specific to summertime. Next slide, please. All right, so one of the first things we think about is sunburns. Now, normally, sunburns aren't treated in a burn center, but we have had a couple times when people got such a severe sunburn as far as percentage that we have had to admit them to the burn center. As a matter of fact, one time, several years back, my former partner, Chet Paul, even made it on the morning show because we had a little baby that had been left out in the sun and had 100% total body surface sunburn. Sunburns can also lead to sun poisoning, and the symptoms of sun poisoning include pain, swelling, headache, fevers, chills, nausea, dizziness, and this is primarily caused from dehydration. Next slide, please. So the treatment is to get the patient out of the sun, put them in a cool shower, not cold, or apply cool compresses. They need fluids, so you try to get them to drink extra fluids. Use ibuprofen and acetaminophen for the pain. And I do recommend aloe vera gel as the moisturizer, although other moisturizers are certainly appropriate. The aloe vera has an anti-inflammatory property that really assists in cooling the burn down or the exposure down. And you want to make sure that you completely cover any sunburned areas if you go back outside. Next slide, please. Now, immediate medical care is needed if somebody with sun poisoning has any of the following symptoms. Sunburn that forms blisters and cover a large area, facial swelling, fever and chills, upset stomach, headache, confusion, faintness, and signs of dehydration. That's because, well, with the blisters, if it's a large surface, then that's a secondary burn, and that meets criteria for the ABA for referral to a burn center. But for all the other things, is usually if they have these signs, you may need IV fluids to reverse the dehydration. Next slide, please. So the way we want to prevent this for all of us is to wear sunscreen that is at least 30 and that it says broad spectrum on the label. And we want to apply that 15 to 30 minutes before going out in the sun and reapply every 2 hours and after you've been sweating or have been in the water. Next slide, please. Now, my wife's mother was an Australian who my father met when he was in World War II, and she came from a large family. And so my wife has 27 cousins that live in Australia, and so we visit there quite often. And Victoria, the province of Victoria, started the Slip, Slop, Slap, Seek, and Slide campaign to help with sun exposures. Next slide, please. Back in 1980, they started with just the Slip, Slop, Slap, which is slip on a shirt, slop on sunscreen, and slap on a hat. Next slide, please. But in 2008, they added Seek Shade and Slide on sunglasses to their routine. Next slide, please. It was a great success. They estimate that they prevented more than 43,000 skin cancers and over 1,400 deaths from the disease in Victoria between 1988 and 2011. I know one of my wife's relatives who was in Special Forces, Australian Army, and had a lot of sun exposure because of his work, has had over 80 skin cancers removed. And this was, obviously, he got this before this program started. So it really does make a difference. The incidence of melanoma in Victorians younger than 60 age is now stabilizing and even, they think, falling. The number of basal and squamous cell carcinomas among those under 45 are also decreasing. The SunSmart is a very cost-effective mechanism. The advertising, they anticipate that they get about $2.25 return for every dollar they spend on advertising. It was one of the Victoria was also one of the first states in Australia to do away with suntan booths. Next slide, please. Fireworks are a big summertime risk. In 2019, the Consumer Product Safety Commission report showed that there were 10,000 fireworks-related injuries in the U.S. treated by hospitals. Those are only the ones that went to the hospitals. 73% of those happened between June 21st and July 21st. 36% of the total injuries happened to children under the age of 15. And burns is the most common injury, making up about 58% of the total body surface, 58% of the total injuries. You know, people always say, well, the 4th of July must be really busy for you. And I always say, well, it takes till the 5th till they sober up and realize they hurt themselves. It's the hand guys that are busy on the 4th because people notice their fingers missing. Next slide, please. I always say that it's after the first 6-pack of beer that you realize the charcoal's not going good enough and you go get the gasoline. So we see quite a few grilling injuries. Approximately a third of the non-fire grill burns are children under the age of 5. So we recommend safety practices for grilling with friends and family. Always, of course, use your grill outdoors. Create a kid-free zone that makes it at least 3 feet of space around the grill. Never leave a hot grill unattended. Maintain your grill, check it for gas leaks, and never use gasoline to start a charcoal grill. I can't tell you how many times that I've taken care of patients who use gasoline instead of lighter fluid to start a grill, and they get a big flash and a big burn. Next slide, please. So there are safe ways of doing this, and the safest way is probably the chimney. It's fast, it's cheap, and it's very efficient. Next slide, please. Second safest, probably using a electric starter. Next slide, please. If you decide to use lighter fluid, we recommend these following steps. Arrange your charcoal into a pyramid shape. Cover it with the fluid, but no more than a 1/4 cup per pound of charcoal. And after you apply it, wait 30 seconds so you get some dissipation of the vapors, and then light them. Next slide, please. The other burn that we see predominantly in summer times are burns from tar or bitumen. People are working on roofs and on roads, and this is the exception to the rule that we don't cool a burn over 5%, because we have to stop the burning process. So the molten material has to be covered with cool water to stop the burning process. Once you get the burn cooled, you can remove the tar or bitumen with anything greasy. Mineral oil works, petroleum ointments worked. My former partner used to like to use mayonnaise. I usually just use mineral oil or bacitracin. Next slide. So with all burns, we have to determine the extent of the burn and the depth of the burn, because that determines how we're going to treat this patient. That also determines their risk of living and dying. So the rule of nines is something that's fast and easy for everybody to use and do. And it, in the good hands, is very accurate. However, in the uninitiated hands, it often will be an overestimation of what the burn size is. The other thing you can do, especially for children who do not follow the rule of nines, is the rule of palm. And that is, everybody's palm is 1% of their body surface area. So you imagine how many of the patient's palms would cover the burn, and that'll give you an accurate estimate of burn size. Next slide, please. As I said, children are not just small adults, so they have a different proportion. Their head is much larger in proportion to their body. So unless you have a Lonbauer diagram, I recommend the rule of palm. Next slide, please. So the palm is 1% body surface area in children as well as adults. Next slide, please. So resuscitation. We use the modified Brook formula, which is 2 cc's per kilo per percent body surface area burn, with half the fluid in the first 8 hours post-burn. Now, kids, because of their larger body surface area to mass ratio, need 3 cc's per kilo per percent body surface area burn, half in the first 8 hours post-burn. And any child under 30 kilograms also does not have enough enough glycogen in their liver to survive a burn resuscitation. So in addition to their resuscitation fluid, they need D5 half normal saline at a maintenance rate. And however you like to calculate maintenance rate, I usually use 40 plus weight in kilograms. The Parkland formula, which we do not use, is 4 cc's per kilo and half over the first 8 hours. And that's the same for adults and pediatrics. It's non-prejudicial. It over-resuscitates everybody. Next slide, please. So in burn care, we use lactated ringers. And I have 2 to 4 here to show the range between the Parkland formula and the Brook formula. But the reason we use lactated ringers is because if you use saline at this rate, you'll make the patient acidotic. Lactated ringers is an acidic solution, but the lactate goes to the liver and is converted to bicarb, buffers the solution. Anybody that has over a 20% burn needs a nasogastric tube and a Foley catheter. The nasogastric tube is because over 20% burn reliably will have a gastric ileus. And especially if you're going to transport the patient by flying them, the gas bubble would enlarge and cause vomiting and potential aspiration. The Foley catheter is required because that's kind of our Euro swan. That's going to help us determine how we're doing with our resuscitation. Pre-hospital, we recommend just clean, dry sheets. We don't recommend putting creams or lotions on them. And even from the initial hospital to the transfer to the burn center, we do not recommend putting any creams on because we'll just have to take them off anyway. The exception, of course, is if it's going to be a prolonged time because you can't get transport. You should never put ice on a burn. It actually deepens the depth of burn. But you can use cool running water. Matter of fact, there's a good study out of New Zealand about 6 years ago that showed 19 minutes of putting a burn under running cool tap water decreased the depth of burn. 20 minutes wasn't better, and 18 minutes wasn't as good. You want to elevate the burned extremities in the head to try to decrease the amount of swelling. We do recommend, except for tar burns, that you don't cool a burn over 5% because you can make the patient hypothermic. And burn patients, their thermostat in the hypothalamus is reset so that they want to be at a higher temperature. Matter of fact, we don't consider a temperature under 102.5 Fahrenheit to even be a fever in a burn patient. And burn patients are very metabolically stressed if they get cold. Next slide, please. So we definitely need an IV in any pediatric burn over 15% or adult burns over 20% because they're going to need IV resuscitation. Toddler infants between 10 to 15, you sometimes can get by with oral resuscitation, and the same with adults with 15 to 20. You can often get by with oral resuscitation, but not always. Next slide, please. So our initial calculation is using either the Parkland or the Brook formula, or the Shrine has a formula of their own. It's just an estimate, just something to get it started. My former mentor, Bill McManus, who was trained at the University of Nebraska as a resident, always said that all the formulas are just there to keep the patient alive until the real doctor shows up. And by that, I mean somebody who really understands how to resuscitate a patient and follow all the signs. What we're looking for is a urine output between 30 and 50 cc's an hour in adults, 1 cc per kilogram per hour in children, and 1.5 kilograms per hour in infants because their kidneys do not concentrate as well. Now, some places you will read 1 cc per kilo per hour in adults also. That came out on a pamphlet that came out of the American College of Surgeons Committee on Trauma. Nobody admits to putting that in that pamphlet, and it was put in there by error, but it has gotten out there and it has become dogma for some, but you don't need more than 50 cc's per hour in an adult, no matter how heavy they are. The other indicators are mental status, because there is nothing in a burn that could cause or should cause a change in mental status. I have had at least 5 people with over 90% burns who walked into the emergency room under their own power. We do also want to follow the resolution of the base deficit, and we are looking for an appropriate tachycardia. Burns should have a tachycardia. Matter of fact, it's often an ominous sign if a burn especially over 30%, does not mount a tachycardic response. But we're talking 110, 115, not 130, 150. And then we also look for follow the blood pressure. Although, again, my former mentor, Bill McManus, used to say, taking a blood pressure in a burn patient in the first 8 hours is just to give the nursing staff something to do. The other indicators are much more important. Next slide, please. We do not recommend bolus therapy. If you give boluses, it is rapidly lost and the effect is rapidly lost. The hypovolemia from a burn injury is gradual in onset. As a matter of fact, there's something called type 2B underfilling, and that is going to be in existence for at least 72 hours. And you're not going to be able to replace the whole plasma volume deficit in that period of time. Boluses exceptions are profound hypertension, of course, delay in resuscitation, the rates that you have to do to get, if somebody shows up, for instance, 7 hours after the burn, you only have 1 hour to get the 8 hours worth of fluid in. That's really a bolus. People with or pre-existing dehydration, people with pre-existing dehydration are those that are working in hot environments, like on roofs and on roadways and 110 degrees like we've been having. And also people who have diabetes, people who are drinking alcohol, and the elderly. The elderly are instant people, you just add water. Mechanical trauma and burns, you treat the mechanical trauma more importantly than the burns. The golden hour does not apply to burns, it does apply to mechanical trauma. Next slide, please. We say that an emergency tracheostomy is a failure of good medical care. That is not to say that if somebody needs it, you shouldn't do a tracheostomy. What I mean by that is that if you get to the point where you need an emergency tracheostomy, somewhere along the line, somebody missed that the airway was becoming compromised. I would rather take a tube out when the patient gets here that didn't have to be there than to have a patient code 3 blocks away because they didn't have a tube. And I've had both of those happen. Even in children, we've seen with scald injuries, sometimes if there's a large scald injury, because of the inflammatory response, if they get excess fluids, they can have airway swelling and end up needing intubated, even though there's no inhalation injury. Next slide, please. All right, pain control. Non-steroidals really don't work on burn pain. So we're really looking at narcotics. Morphine is cheap and it works effectively. As it turns out, methadone is probably a better drug for burn pain because it acts on 2 separate receptor sites. But a lot of people are hesitant to use methadone. You probably should get an EKG before you use it. So we, at least to begin with, we recommend morphine. The platelet inhibitory problem with non-steroidals are also troublesome for us in burn patients, and despite the fact that non-steroidals really don't work all that well. Since all burn patients are at risk for hypotension and decreased renal blood flow, that's another reason non-steroidals are not indicated. Matter of fact, they're contraindicated, such as like Toradol. Also, pain control should be given by intravenous route because of the edema from the burn and the inflammatory response and the type or the third spacing. Subcutaneous and intermuscular routes are not really that reliable. Next slide, please. Burns are considered a tetanus-prone wound. So if there are more than 2 prior vaccinations, if greater than 5 years since the last one, they should have the toxoid. If less than 5 years, nothing's required. If less than 2 prior vaccinations, you need to give the toxoid and take it at a different site. Next slide, please. The criteria for referral to a burn center is important to know, if for no other reasons that lawyers know this. The burn size, any burn greater than 10% in anybody less than 10 or over 50 should be referred to a burn center. Anybody over 20% should be referred to a burn center. Anybody with full thickness burns greater than 5% should be referred to a burn center. Anybody with associated inhalation injury, a comorbidity that complicates burn care, or multi-system trauma in burns should be taken to a burn center. Electrical or chemical burns are indication for a referral to a burn center, and burns to hand, face, peritoneum, and across the major joint also. Now, I say referral, I didn't necessarily transfer. So some of these things, like somebody has a palm burn because they put their hand on the grill. Well, palm burns almost always heal, and they don't necessarily need to come, but just give us a call. And if you have telemedicine capability, we'll take a look and we'll discuss it with you, and we'll give you our recommendations and when we think if you need to send the patient, when that would be. And I tell people that when you do that, ask for the name of the person you talk to and put it in the patient's chart, because that way you've documented that you referred the patient to the burn center. And I have no problem with you putting my name in the chart that if we talk and saying what advice I gave you. Now, burns with trauma. Nobody should go past a trauma center to get to a burn center if they have both burns and trauma, because nobody dies of the trauma in that first hour, but they will die of, nobody dies of burns in the first hour, but they will die of the trauma in the first hour. So the trauma needs to be stabilized, and after the trauma is stabilized, then they get transferred to the burn center. Next slide, please. Escharotomies. Escharotomies are required when the burn is circumferential and it is inhibiting blood flow. When the burn is circumferential, initially you'll have flow, and as you start resuscitating the patient because of the inflammatory response and the amount of fluids, the tissue is going to swell and it can't expand because the skin is leather tight from the burn. So we have to cut the eschar to allow it to expand. So you don't usually see the need for escharotomies until you start the resuscitation. What we do is we don't wait for loss of pulses. That's way too long. You can have too much nerve damage. So if somebody has a change in the sound of the Doppler flow is when we do our escharotomy. So if it goes from triphasic to biphasic, that's enough indication that that patient needs an escharotomy. These can be done outside the operating room because they're not painful because you're cutting through dead tissue. You can use either scalpel or cautery. Now, I will say if you use cautery, sometimes the patient will fill that a little bit. You do completely release the skin, and you have to make sure you go from unburned skin to unburned skin, and especially crossing any joint that is burned, because that's a real tight constricting point. Then you'll want to, of course, control the bleeding before you transport the patient. If somebody has a circumferential chest burn, they may have difficulty ventilating, and that's when you cake and make an escharotomy from shoulder to shoulder at the level of the clavicle, across the rib cage at the lower part of the chest, upper part of the abdomen, and then connect those two with midclavicular lines. Next slide, please. Transportation is dependent often on what we can get. Air ambulance versus ground, we usually use distance, terrain, and weather to determine that. Longer distances, air flight is probably more beneficial. Short distances, it's really not worth the cost. And helicopters especially don't fly very well in bad weather. Helicopter versus fixed wing, that's typically related to how far the range of the helicopter is. And most helicopters over 150 miles probably should go fixed wing. There are a few helicopters that can cover that distance, but not many. Next slide, please. There are some unique problems in air medical transportation. I spent several years at the Army Institute of Surgical Research, also known as the world famous burn center at 47 Houston, Texas. And our motto was anytime, anywhere. We would fly over the world, bringing our service members back to San Antonio to treat them for burns. And depending upon the aircraft we use, we can have some very difficulty having space and lighting, especially the Hueys. They were particularly bad. Air Nightingale was like a flying ICU, so that wasn't a problem there. Noise level is also a problem. Temperature fluctuations as you get to altitude, especially in unpressurized aircraft, and Boyle's law, which it says that as you get lower in pressure, the volume of air will expand. That's particularly troublesome for our endotracheal tube. So you either have to continually check your endotracheal tube balloon, or instead of filling it with air, fill it with saline. Contraindications to air medical transport are marginal respiratory reserve. That's the primary one, because even if in a pressurized cabin, as you get to altitude, the FiO2 provided to the patient will go down. Active hemorrhage, active fever, dysrhythmias, recent intracranial or intraocular surgery, recent abdominal surgery can also, because the air in there can expand and cause discomfort, and of course any intracranial or intraocular air. Next slide, please. So we recommend that if you get a significant burn and you are less than 40 minutes from the burn center, just scoop and run. If you do put IVs, we recommend 2 large bore IVs. And what we tell our EMS staff is we don't expect you to sit there and try to calculate the percent burn and calculate the rate. Just if they're over 15 years of age, start them at 500 cc's an hour of LR. Between 5 and 15 years, we recommend starting at 250 an hour. And less than 5, we recommend transporting with IV unless it's going to be a long transport. Again, just a clean, dry sheet and a blanket to keep them warm. And do not apply ice, and do not cool if it's over 5% body surface area. Next slide, please. We do recommend leaving the blisters intact. Don't apply any topical agents until we get to us. Check the tetanus status. IV antibiotics are not indicated in acute burn care. Now, if the transfer is delayed because of weather or inability to get transport, we do then recommend going ahead and debriding the blisters and applying agents. The most common used is Silvadene. Blisters are really more an emotional issue than a scientific issue. Though there are those of us in the burn communities who are always poppers and never poppers and sometimes poppers. I'm a sometimes popper. For me, I think that the fluid in the blister is protective, and I think it's helps healing. There are some people who look at blister fluid and think there's some agents that delay epithelialization, so that's why they pop them all. For me, if I think the blister will stay intact, I'll leave it intact. If I think it'll rupture easily, I will debride it. Next slide. So Silvadene, as I said, is probably the most common burn agent we use. Each gram of Silvadene contains 1% of 10 milligrams of microlysed silver sulfadiazine. Silvadene is a sulfa drug. So if somebody is allergic to sulfa, you can't put Silvadene on them. The pros of Silvadene is it's bactericidal, it's very soothing to the patient, and it penetrates eschar, but not very well. It can cause a transient leukopenia, and it's, of course, a sulfa drug. And there is resistance to Silvadene, although very rare. And about 5% of people will develop a rash to Silvadene who are not previously known to be sulfa allergic. Next slide, please. Dr. Mendelsohn, in the time of the Vietnam War, was asked to study a drug that had been found to be carried by German soldiers toward the ends of World War II. It was a powder that they were putting on their wounds. And when we liberated the Nazi death camps, we found this drug, and they've been doing studies on it. It had been studied in the United States as an IV antibiotic and found not to be useful, but the Germans found it very useful as a topical. Their studies, of course, were done in unethical means, so it wasn't really used in the States until they were looking for something to treat gas gangrene in Vietnam. So Dr. Mendelsohn was assigned the job to test out mafenide acetate, and turns out goats have Clostridium difficile, Clostridium perfringens on their skin, just like we have staph epidermidis. So if you put C4 explosives on the hip of a goat and blow it up, it will reliably get gas gangrene. So Dr. Mendelsohn randomized goats to mafenide acetate or surgery, and it turns out the goats that had the mafenide acetate did better. Next slide, please. So she decided that it would be great for burns. She called the Army Burn Center and said, you need to start using this on burns. So what they did is they sent her to Nam, and she ran a burn center in Nam that treated civilian casualties. And she had a 20% solution and a 5% solution. And she sprayed a 5% solution on faces, the 20% on the rest of the body. And her infection rate was lower than the traditional burn centers. It does penetrate. Mafenide acetate, also known as sulfamylon, is not a sulfa drug. So it can be given to patients who have a sulfa allergy. It penetrates burn eschar very well. It has an excellent spectrum of activity, but it's bacteriostatic, not bactericidal. It is painful if you do have a partial thickness burn. Matter of fact, my burn patients sometimes refer to this as scream cream. About 5% of people will develop a rash. It is a carbonic anhydrase inhibitor, so it can cause a mild metabolic acidosis and an increase in respiratory rate as the patient tries to blow off the CO2. Next slide, please. Silver nitrate is a topical we used to use. We don't tend to use it anymore because it turns everything black. Turns the patient black, turns the walls black, turns the floor black. Matter of fact, when we used to use this, we actually would take garbage bags and line the floor and the walls up to 4 feet high to try to save them. It has a very good spectrum of activity, and it's the least toxic of all antimicrobials to new epidermis. It's, however, a hypotonic solution and will leach electrolytes into the dressings, and it penetrates very poorly, and it has to stay wet to work. Next slide, please. So Rob Burrell, who's a mining engineer in Saskatchewan, Canada, at the university there, came up with a different delivery mechanism of silver. Next slide, please. he came up with Acticoat, which is a silver impregnated telfa. It leaches silver at a consistent rate for 72 hours. It has a very wide spectrum of antimicrobial activity, and it modulates with teleproteases. It is costly as a sheet, but it's cost effective because it can be used for 72 hours and doesn't necessarily have to be changed. Next slide, please. It kills rapidly in as little as 30 minutes, and it consists of 3 layers, an absorbent layer, and then the outer layers, which are non-adherent. Next slide, please. Then Therabond came out later. It's the exact same process of bubbling the silver on the product that was used by Rob Burrell to create Acticoat is used in create Therabond. As a matter of fact, the person who created Therabond used to be in Rob Burrell's lab. The difference with Therabond is it actually has a sidedness to it that Acticoat doesn't. There's a waffle side and a smooth side, and the waffle goes towards the wound. The other difference is Therabond is active for 14 days. It leaches a constant amount of silver for 14 days. Next slide, please. The other product that is out there that's used in burn is Silverlawn. I actually studied Silverlawn as a research product when I was at the Institute of Surgical Research. The technology we were using to put silver on nylon required an electric current to release the silver. And so we never really got it to market. But since then, the company has used the same process that Acticoat and Therabond use to bubble the silver on, so it leaches at a constant rate without the electric current. All these products have the same level of kill, the same spectrum. They just have different properties because of what it's bubbled onto. The Silverlawn doesn't absorb well, and it sometimes will develop a film onto it. The Therabond absorbs well, wicks well, but it sticks. Acticoat's kind of in between. So we base what we use really on cost. So whoever gets the best contract with us, we use because they're virtually interchangeable. The nice thing about the Silverlawn is that it actually has a glove you can slide on for burned hands, and that's kind of handy. Next slide, please. Zeroform is a really nice burn dressing for partial thickness burns. It has a finely woven mesh, and it has bismuth as its antimicrobial. And it can be used as a temporary skin. What we do is we debride the loose epithelium, you wash it with an antibacterial soap, you apply the Zeroform, and then apply a compressive dressing. And we leave that in place for 24 to 48 hours. Then we take off the outer dressing, and if the Zeroform is stuck, you just leave it in place and let it lift off as the burn heals underneath. If it's not stuck, then you take it off, wash it, and either reapply it, or if it turns out to be a deeper burn, go to something that'll penetrate better. The Children's Hospital in Toronto compared Zeroform to BioBrain. BioBrain is a bilayer collagen matrix and silicone-backed temporary skin, and they found that Zeroform was equivalent to BioBrain in its effectiveness and is at a fraction of the cost. Next slide, please. Bacitracin has a good spectrum of activity. It's clear, so if especially on faces, people can go out in public and they don't get stared at because they don't have a bunch of white goop on their face, and it's soothing. The disadvantage is poor penetration, so it's really only good for partial thickness burns. And it's not very toxic to epidermis. So that's another good point about bacitracin. Next slide, please. Xenograft. We really like Xenograft for our partial thickness burns. The nice thing about Xenograft is it has growth factors within it that promotes the healing. It seals the wound so it doesn't hurt as much, so it alleviates the pain. It used to be, when I first started burn care, all of our Xenograft came from Jimmy Dean. Jimmy Dean sold the whole hog. It's my understanding that it's hard to skin a hog unless you dunk it in hot water. And Jimmy Dean didn't do that because he sold the skin to the medical community. Well, then the FDA said, well, you can't take an animal that you're using for medical products and also sell them for food. So Jimmy Dean got out of the xenograft business, and it was taken over by Brennan first, and then by a company out of Germany that I'm blanking on the name. And they have recently stopped producing the xenograft. So what we use for our xenograft now is a burn wound matrix that's made from porcine small intestine submucosa. And it provides a three-dimensional extracellular matrix, which allows for migration of the host cells, and its thickness allows for fixation and retention of sutures or staples if necessary. However, what we do is we use cyanoacrylate, and because most of our xenograft we do in our tub room with the patient awake and just under light sedation. So we use cyanoacrylate to fix it because it doesn't hurt. Next slide, please. Allograft, it's more expensive than xenograft, but it also is a great dressing for partial thickness burn. It has all the same wonderful properties as it has growth factors, and it has a matrix for the cells to migrate across. When we use allograft, are in those who have a religious reason that they feel that they cannot accept xenograft, and that primarily is the Islamic community. The Jewish community will accept xenograft on the outside, but the Muslims tend not to. Next slide. I am open for any questions.
Thank you so much, Dr. Voigt. That was very enlightening, and I think a few of us will never look at Jimmy Dean again the same. Does anybody have any questions? Again, please put them in the Q&A box if anybody has any questions or comments for Dr. Voigt.
We do have two questions in the Q&A. The first question is, what about using fentanyl for pain control?
Oh, fentanyl's perfectly fine. It doesn't last as long, so you have to redose it more. But it's a perfectly good drug. Also causes patients' noses to itch more than morphine does. So if they have a burn to the face, it will induce encourage scratching more. But I have no problem with fentanyl. We for a while we couldn't get morphine PCA cartridges, and we were using fentanyl in our PCA. I think it's really appropriate for a PCA because it's short acting and patient controlled. I think it's good. No problem with it.
Dr. Voigt, it looks like there's another question here. Someone asked, what are your thoughts on plastic wrap to cover burns?
Yeah, I don't see any reason to do that. Not, if you're going to use it to hold an antibiotic ointment under it, I guess it's okay. It will seal it. And I know there is a couple dermatologists who recommend putting a steroid cream on and then wrapping it with plastic. It'd probably be okay for a first degree burn, but I wouldn't do it if the wound was open. If it was a partial thickness burn, you wanted to put some antibiotic ointment on and wrap it with the plastic wrap just to seal so the air doesn't get to it, I don't see any harm in it, but I don't see any particular benefit either.
Dr. Voigt, another question about pain control. What about ketamine for pain control?
Well, ketamine is a dissociate anesthetic. It doesn't really control pain. It just dissociates the patient from the pain. We use ketamine quite a bit when we do our debridements and xenografting in the tub room. But I always give a benzodiazepine first to avoid the nightmares that ketamine can cause. And I also always give a narcotic because it really doesn't help with the pain. The way I give ketamine is I take 1 cc per kilo of ketamine and draw it up in a 60 cc syringe. I give them Versed until they can't say Methodist Episcopal, and then a couple milligrams of morphine, and then I inject the ketamine and watch their eyes. As soon as they get nystagmus, I stop injecting the ketamine and we do the debridement. I always have a beta blocker on hand because with the ketamine, even at that slow infusion rate and that low dose, you can get tachycardia and have hypertension.
Dr. Voigt, there's another question regarding fevers and air transport. Why is that contraindicated?
Because it's contraindicated because it increases the risk for seizures and arrhythmias.
We have another one in here that says, my entire EMS career, we used saran wrap to cover burns versus clean and dry sheets. Thoughts or concerns? I think we kind of just talked about that one, but you did emphasize clean, dry sheets in your speech today. Do you have anything to elaborate on that?
No, I mean, it's just clean dry sheets are everybody has them. You don't have to do anything special. Doesn't take any special amount of time. Wrapping with plastic wrap, I mean, it all depends. I mean, if there's open wounds, in other words, there's blisters that have ruptured, and you wrap it with a plastic wrap without putting any washing the wound and putting an antimicrobial on it, you basically have just created an abscess because you have bacteria that's trapped now and can't get out.
Dr. Voigt, can you elaborate on what to watch for when using methadone for pain control and the risks?
Well, the main problem with methadone is it prolongs QT. And so you can get testosterone points from prolongation of the QT. And so that's why the EKG. So if they have a normal QT interval, I don't have any problem with using the morphine. And actually, we in the burn community are now becoming, most of us, to the belief that methadone, sorry, I said morphine, I meant methadone, that methadone is probably the narcotic of choice for burn pain. But the risk is the prolongation of the QT.
Thanks, Dr. Voigt. We have another question here. There's a new critical access hospital nurse that attended today. If an ER patient is completely covered in burns, where would you recommend we try and insert IVs?
Any port in a storm. You know, there's nothing about the burn skin that's any dirtier than the unburned skin acutely. So it is okay to just prep it however you normally prep skin and stick the IV in and get them for transport. And once they get here, we will get some way to get a clean IV in them, even if it includes excising skin and putting down skin or some type of artificial product to put a clean IV in. So yeah, acutely, we prefer to go through unburned skin, but if that's not really a choice and there's a nice choice vessel that you can see that's got burn over it, go for it. One thing I will suggest though, if you have to do that, you're probably better off suturing that IV in than taping it in, because tape doesn't stick well to burn skin.
Dr. Voigt, along those same lines, are IOs contraindicated for burns?
Absolutely not. And especially in the kiddos, we get quite a few burn kids that come in with IOs in. Perfectly acceptable. And again, even if it's a area under a bone under a burn, if it's acute, prep it like you normally would. Is no higher risk than going through unburned skin acutely.
Looks like there's one more question so far in here. What is the highest burn percentage of burns that you have seen survive?
96%.
Oh,
If you don't have your scalp burned, I can cover your whole body with your scalp. Just takes a lot of operations.
There's a lot of great compliments today. Very informative talk, outstanding information. A lot of the rural facilities are appreciating the information, learning what to do and for referrals and transferring patients to a burn center.
Very good, thank you.
Dr. Voigt, for those facilities, non-burn facilities, obviously, that are on, what would you recommend? You know, you went over a lot of products that we use in burn, but for those non-burn facilities, and from maybe a cost containment perspective, what perhaps you would recommend that they might have as part of their part that they could use for the first 24 hours, you know, or first few hours of care when burn patients come to their facility, along the lines of the zero forms or silvadines or bacitracins.
Well, I mean, I think zero form is for partial thickness burns is really good. Partial burns to the face, bacitracin. You know, one of the silver products, either the Acticoat Therabond or Silverlon. The nice thing about those is they have a constant release of silver, and depending upon which product you use, you could put that on and not see the patient back for 3 days, and then not have to do a dressing change. So again, the product initially is more costly, but the fact that you didn't have to see them back twice a day, which you do for Silvadine, or even daily, like you do with the zero form, it ends up being cheaper in the long run. But it doesn't. All those silver products that I mentioned only penetrate 5 millimeters into the eschar. So if it is a full thickness burn they're treating, then they really should be using something like Silvadine or sulfamylon. They probably wouldn't have use for sulfamylon in other cases where Silvadine they could use for road rashes and other products like that. So for a smaller hospital, I think Silvadine would be the product that I would have in stock.
Excellent.
Along those- oh, go ahead.
I'm sorry, go ahead, Mark.
Oh, I was saying along the same lines, what are your feelings on tilapia skin?
It's fine. You know, it's a xenograft, and it has the same type of properties that all the xenograft has. There are growth factors that are contained within it, and it provides a matrix. I just don't have a good supplier. I wouldn't hesitate to necessarily use it. It's the research that's done on it shows it's effective, but the storage can be an issue. Whereas our xenograft product we use now is it's stored on the shelf. It doesn't have to be refrigerated, so it's much handier for us. And the other limitation with tilapia skin is the size. You can't get really big pieces. And so somebody comes in and they have a 20% partial thickness burn, you're spending a lot more time in the tub room and using a lot more cyanoacrylate, whereas the other xenograft products that we use have some really big sheets that will cover almost an entire chest. So it's for the bigger burns, it's better. And so the size variation with tilapia skin just doesn't provide as much leeway as the other xenograft products.
All right, we do have another question. Is there psychological counseling for burn patients?
Yes, there is. And there also is a support group called it's out of the Phoenix Society, and it's called, I'm blanking on its name. I'm sorry, it'll come back to me later. But there is a support group. We run it out of our burn center, and what that group does is it pairs former burn survivors with new burn patients, and we try to match our mentors to the same type of injury that our patients have. SOAR, that's the name of the support group. It's called SOAR, and it's a product that we get out of the Phoenix Society. So there's both peer support and then there's psychological support. The problem is it's almost impossible to get insurance to pay for any type of psychological support for the significant other or family of a burn victim. And, you know, they go through the stress too, and they can have post-traumatic, even though they're not burned. The other program we have along the same lines as psychological support, we do have a school reentry program where if we have a burn child, one of our burn educating nurses will go to school with the child the first day they go back to school. And with the child's permission, they will explain what happened, and they will explain that, you know, why they're wearing these funny looking garments and all about it to help get them reintegrated back into their school.
Dr. Voigt, it looks like Eric had mentioned it's called the SOAR, Survivors Offering Assistance in Recovery. Does that sound?
That's right. Yep. Well, Eric should know.
I don't see Judy. We'll turn it over to you on the dash tool.
All right, thank you. Yeah, so I just wanted to make one more comment for those facilities out there, those non-burn facilities. Please take down the information on the screen. Dr. Voigt and his team are fantastic resources for you across the state, and him and his team would be happy to consult with you guys if you guys have burn patients in your facility. So please take advantage of that. And Dr. Voigt, thank you so much for your presentation today. A lot of great information. One thing I wanted to mention before we close out is something called the DASH tool. This is an initiative with Asper Tracy, and it stands for Disaster Available Supplies for Hospitals. There is a burn module that the draft has just kind of been completed, and we're working on the online part of the tool. But essentially what it does is it allows the facilities and their suppliers to access this tool, go over the burn supplies that perhaps would be needed during a surge of burn patients. And that way you would have more supplies on hand for a disaster, for a surge. And this tool is not to be used during a response, but part of your planning. So it's the preparedness side of your disaster planning and response that this tool is really useful. And so there is a webinar, an Asper Tracy webinar on August 15th that we invite you all to. They'll put the link in the chat if you guys would like to join that and kind of get introduced to this module. I think it'd be really helpful. This is one of 3 other modules, I believe. There's a PPE module, a trauma module. There's a burn, like I said, the burn module. So these would be used all together. So for example, this burn module only has burn dressings in it. So if you needed eschar supplies, you might have to go to the trauma module. So there are a handful of modules that you'll be introduced to, but this particular burn surge module, or burn supply module, I'm sorry, will be introduced on this webinar on August 15th. So are there any other questions?
I didn't see any more questions in the chat here. Thank you, Dr. Voigt, very much. And thank you, Judy, for the presentation today. Will be continuing education that is available. We'll put the next slide up here for a couple minutes for those participants. We appreciate you joining us. For future education opportunities, please visit us on Facebook, LinkedIn, or our website, regionviidhre.com. Thank you.
Thank you, everyone.
Thanks for having me.